Good morning, class. Today we will discuss about working length determination. The historical perspectives of working length determination is: in the end of 19th century, working length was calculated when file was placed in canal and patient experienced pain. In 1899, Kells introduced X-rays in dentistry. In 1929, college studied the anatomy of root apex in relation to treatment problems. In 1955, Cutler microscopically studied the microscopic anatomy of root tip and decided that filling to the radiographic apex was an unwise clinical procedure, contributing to post-operative pain. In 1969, Inno significantly contributed to evolution of electronic apex locators. Here are some definitions in working length determination. The definition of working length is from 7th edition of the Glossary of Endodontic Terms is the distance from a coronal reference point to the point at which canal preparation and obturation should terminate. Reference point. It is a site on the occlusal or incisal surface from which measurements are made. This point is used throughout canal preparation and obturation. This is the diagrammatic representation of anatomy of the root apex from the Cutler studies. Anatomical apex. It is the tip or the end of the root determined morphologically. Radiographical apex is the tip or end of the root determined radiographically. Here is the diagram of anatomical apex and radiographical apex. Cementodentinal junction, which is called as CDJ. The region where the dentine and cementum are united, the point at which the cemental surface terminates at or near the apex of a tooth. CDJ does not always coincide with apical constriction. Location of CDJ is 0.5 to 0.3 mm short of the anatomical apex, which is given by Lange. Apical foramen, the main apical opening of the root canal. It is frequently eccentrically located away from the anatomic or radiographic apex. The apical foramen deviates from the root tip in at least two-thirds of all teeth. This deviation occurs towards the buccal or lingual aspect twice, often as it does towards the mesial or distal aspect. Lateral canals. Periodontal vessels curve around the root apex of a developing tooth and become entrapped in Hertwig's epithelial root sheath, resulting in formation of lateral canals. Apical delta, branching pattern of small accessories canals and minor foramen seen at the tip or apex of some tooth, called as apical delta. There is one more definition in this topic: apical constriction. The apical constriction, which is also called as minor apical diameter, the apical portion of the root canal having the narrowest diameter. This position may vary, but is usually 0.5 to 1 mm short of the center of the apical foramen. The minor diameter widens apically to the foramen major diameter and assumes a funnel shape. Topography of the apical constriction, which is given by Dummer and called as Dummer classification. In type A, traditional single constriction, present 46%. Type B, tapering constriction, present in 30%. Type C, multi-constricted, present in 19%. And the type D, parallel constriction, present in 5%. Major and minor diameter. Distance between major diameter and minor diameter, 0.524 mm in 18 to 25 years old, and 0.659 mm in 55 years plus. Significance of working length determines how far into the canal the instruments are placed and work, and thus how deeply the tissues, debris, metabolites are removed. Second point limits the depth to which the canal filling may be placed. Point 3 affects the degree of pain and discomfort that the patient will feel following the appointment. Number 4, if calculated within correct limits, it will play an important role in determining the success of the treatment, and conversely, if calculated incorrectly, may cause the treatment to failure. Failure to accurately determine and maintain working length. If the length is too long, it can lead to perforation through apical constriction. It can lead to overfilling or overextension, increased incidence of post-operative pain, prolonged healing period, lower success rate, owing to incomplete regeneration of cementum, periodontal ligament, and alveolar bone. If the working length is short, it can lead to incomplete cleaning, underfilling, persistent discomfort, incomplete apical seal, apical leakage, which supports the existence of viable bacteria and contributes to a periradicular lesion. Lower success rate. Prior to establishing a definitive working length, coronal access to the pulp chamber must provide a straight line access into the canal orifice, thereby facilitating subsequent canal penetration. In anterior teeth, failure to remove the lingual ledge or incisal ledge often impedes this straight line access, resulting in lack of depth penetration to the CDJ. Failure to locate all canals present or instrument penetration into the canal wall with ledge formation. In posterior teeth, primarily molars or multi-rooted premolars, failure to remove cervical ledges or bulges results in missed canals or binding of the penetrating instrument in the coronal third of the canal with ledge. How to measure working length? A silicon stop is common aid for evaluating the working length measurement and returning to a secure reference point. Care must be taken to assure that the stop is placed on the file and measured at a right angle to the file. Otherwise, differences in length of a millimeter or more between files may occur, leading to either perforation and striping of the apical foramen or inadequate cleaning and shaping of the apical seed with corresponding loss of length. Here you can see a curve with a stopper. Commercial stops made of metal, silicon, rubber, and plastic, which is commonly present as teardrop shape, round shape. Advantages: do not have to remove during sterilization. In curved canals, to indicate the curvature, spatial tear, shaped or marked rubber stops can be positioned with the direction of the curve placed in a pre-curved stainless steel instrument. Disadvantages: time consuming, may move up and down the shaft, which may lead to preparations short or past the apical constriction. Metal or silicone stoppers to mark the working length. The stopper must clearly correspond to cusp tip and rest firmly on it. For electronic determination of working length, the silicone stopper left is better than a metal stopper right, because the metal stopper can cause a short circuit. Length adjustment of the stop attachments should be made against the edge of a sterile metric ruler or a gauge made specifically for endodontics. Example, Guidner Endo M Block, which is made by company Dentsply or Malafort, has 32 depth guides in 2 rows. Front row indicators from 10 to 30 mm in 1 mm increments. Some instruments have millimeter marking rings etched or grooved into the shaft. These act as a built-in ruler with the markings placed at 18, 19, 20, 21, 22, and 23 and 24 mm. Methods of working length determination. Radiographic methods, best method, Bregman's methods, Brement's method, Grossman formula, English methods, Wien's method, Cutler's method, radiographic grade, zero radiography, direct digital radiography. Non-radiographical methods, digital tactile sense, apical periodontal sensitivity, paper point method, electronic apex locator. So first we talk about radiographic methods. In best method, it is introduced in 1960. A steel pin measuring 10 mm is fixed to the labial surface of root with utility wax, keeping the pin parallel to long axis of tooth, and a radiograph is taken. The measurements were made with the help of a BW gauge. Brement's method, introduced in 1974, used stainless steel probes of various calibers and length. They were bent at one end at right angles, and this bend is inserted partially into acrylic resin in such a manner that its internal surface is in flush with the resin surface contacting tooth surface. The probe is introduced in the canal such that the resin touches the incision or cusp tip, taking care to see that the bent segment of the probe would be parallel to mesiodistal diameter of crown, thus making it possible to visualize on radiographs. In this radiograph, we can see the reference points are as follows. The marking A shows probe segment, the marking B shows apical end of probe, the marking C shows tooth apex. Grossman's method. In Grossman's method, there is a formula CLT is equal to KLI cross ALT divided by upon ALI, whereas CLT is equal to correct length of the tooth, KLI is known length of the instrument in the tooth, ALT is apparent length of the tooth on radiograph, ALI is apparent length of the instrument on radiograph. A, whereas A is the length of the tooth is measured on the diagnostic radiograph schematic view. This measure, whereas B is the measurement is transferred to a diagnostic instrument prepared with a silicone stop. The instrument is placed in the root canal and a radiograph is made. Whereas C and D are the root canal and working lengths are determined from the radiographs. English method. In English, in English method, we measure the tooth on the pre-operative radiograph, then, then subtract at least 1 mm for safety allowance for possible image distortion. Then set the endodontic ruler at this tentative working length and adjust the stop on instrument at that level. In Wien's modification, we are here, there is modification in length subtraction. If there is no resorption, we will subtract 1 mm. If there is periapical bone loss, we will subtract 1.5 mm. And if there is periapical bone loss plus root apex resorption, we will subtract 2 mm. X-ray grid system, which is given by Everett and Fixot in 1963. It consists of lines 1 mm apart running lengthwise and crosswise. Every 5 millimeter is accentuated by a heavier line to make reading easier. The grid is taped to a film to lie in between the tooth and film during exposure, so patterns become incorporated in the finished film. it is a simple method. There is no need for calculations, but it cannot be used if radiography is spent during exposure. Zero radiography. Zero radiography. An electrostatic imaging system that uses a uniformly charged X-ray sensitive selenium alloy photoreceptor plate in a light-proof cassette. When exposed to X-rays, the charge on the photoreceptor plate dissipated according to tissue density. A latent electrostatic image is produced. This latent image is then transformed into a visible image by deposition of specially pigmented particles. The visible image transferred to a base sheet that can be viewed either by reflected light or a trans-illuminated light. Advantages of zero radiography: produces image of superior quality, age enhancement property and sharper contrast. Radiation levels are reduced to only one third. Rapid, require only 20 seconds to produce a permanent dry image. Disadvantages of zero radiography: large areas of bone more than 2 centimeters are shown better with conventional intraoral film technique than with zero radiography. Greater degree of artifacts than in conventional technique. Direct digital radiography. In this, digital image is formed, which is represented by spatially distributed set of discrete sensors and pixels, which can be taken by radiovisugraphy (RVG) or phosphor imaging system (RVG). There are three parts in RVG: radio part, visio part, and graphy part. Radio part, it means a conventional X-ray unit, precise timer for short exposure times, sensor to record the images. In visio part, video monitor, display processing unit. In graphy part, we have digital storage apparatus. It is invented by It was invented by Dr. Francis Moyers in 1984. Advantages of RVG: low radiation dose, darkroom is not required as instant image is viewed, quality of the image is consistent, greater exposure latitude, image distortion from bent films is eliminated. Disadvantages of RVG: expensive, large disk space required to store images, bulky sensor with cable attachment can make placement in mouth difficult. Soft tissue imaging is not very accurate. Phosphor imaging system. Image is captured on a phosphor plate as analog information and converted into digital format, which is when plate is processed. Advantages: low radiation dose, instant images are formed, image manipulation facilities, receptor is same size as film. Disadvantages: expensive, slight inconvenience due to plastic wraps around phosphoplates, large disk space to store images. Advantages and disadvantages of radiographic method. Here are some advantages of radiographic method, which are: we can see anatomy of growth, we can see curvatures and roots, we can see radio relationship between adjacent teeth and anatomic structures. There's some disadvantages too, which are varies with different observers. Superimposition of anatomic structures, 2D view of a 3D subject, radiation exposure, cannot interpret if apical foramen has buccal or lingual exit, limited accuracy and time consuming. There are some non-radiographic methods too, which are digital tactile sense, Advantages of digital tactile sense: time saving, no radiation exposure. Disadvantages are: in case of narrow canals, one may feel increased resistance as file approaches a apical 2 to 3 mm. In case of teeth with immature apex, instrument can go periapically. In case of anatomical variations in AC, sclerosis, resorption, tooth type, and age, this method becomes unreliable. Periodontal sensitivity test. This method does not provide accurate readings. For example, in case of narrow canals, instrument may feel increased resistance in apical 2 to 3 mm in immature apex, while goes beyond apex. In case of canals with necrotic pulp, instrument can pass beyond apical constriction. And in case of vital or inflamed pulp, pain may occur several mm before periapex is crossed by instrument. Taper point measurement method. This method, however, may give unreliable data. If the pulp not completely removed, if the tooth is pulpless but a periapical lesion rich in blood supply is present, if paper point is left in canal for a long time. The fourth method in non-radiographic methods of determination of working length is electronic apex locator. In addition to radiography, tactile sensation has been used with questionable success. Thus, the drawbacks cited about radiographic length determination, along with increasing concern about radiation exposure, the introduction and development of apex locators was received with enthusiasm. These devices do not assess the position of the root apex, and the name electronic apex locator is not appropriate. Electronic apical foramen locator or electronic root canal length measurement device as a generic name would be more appropriate. Here you can see parts of electronic apex locator. There is a lip hook, there is a file clip, a measuring wire, and a display which have power indicator, length measure indicator, emulsion of enlarging apex, sound indicator. There's a power button for on and off, sound adjustment, demonstration function, and measuring wire socket. Electronic method. Uses of apex locators provide objective information with high degree of accuracy used when a apical portion of canal is constricted. Used in patients with gag reflex and cannot tolerate X-ray in pregnant ladies to reduce radiation exposure. Useful in children, disabled patients, heavily sedated patients, etc. It is a valuable tool for detecting site of wood perforations, testing pulp vitality, determination of perforations caused during post-op preparation, detecting horizontal or vertical root fractures, detecting internal or external resorption. Basic conditions for accuracy of EALs. Canal should be relatively dry. Canal should be free from debris. No cervical leakage. No blockage or calcification of canals. Proper contact of file with canal walls and periapex. There is a classification of apex locators. Types of apex locators based on direct current, original originalometer used by Suzuki and Sonata. Based on AC current, alternating current, there are two types: resistance type and frequency type, and impedance, three types. In resistance type, root canal meter, endometric meter. In impedance type, there is a endocator 400 kilohertz, and in frequency type, there are two types again: subtraction type and ratio type. In subtraction type, index and neo sumo ultima EZ. In ratio type, frequencies root ZX which have a frequency of 0.4 kilohertz and 8 kilohertz, and frequencies AFA Apex Finder Elements Diagnostic Unit. First generation apex locator, resistance apex locators, measures opposition to flow of direct current, i.e. resistance. These apex locators have a built-in resistance value of 6.5 kilo ohms and are attached to the patient's lip on one side, and the other side is attached to the file. The file is then advanced into the canal until it touches the periodontal tissue at the apex, which then completes the circuit. Example: root canal meter, Onuki Medical Corporation, Japan. Endometric meter S2, Onuki Medical Corporation, Apex Finder, and Ultima EZ. In this figure, you can see the structure of the tooth during root canal treatment in terms of electrical conductivity and the resistance of the model. Advantages: easy to operate, used KTAP files, digital readout, detects perforations, built-in pulp tester. And the disadvantages are requires a dry environment. There should be no carries or defective restorations. Requires calibration. Requires a lip clip which could contact patient sensitivity. Perforations can give false readings. Contraindicated in patients with pacemakers. Second generation apex locators. Introduced the concept of impedance-based AL, and the principal law is measures opposition to flow of alternating current or impedance. The tooth exhibits increase in electrical impedance across the walls of the root canal, which is greater apically than coronally. At the cemento-dentinal junction, the level of impedance drops dramatically. The examples are Digipax, Endocator, Digipax 2, Exact Apex, Sono Explorer, and Endo Analyzer. Advantages of second generation EAL is no patient sensitivity, operates in fluid environment, analog meter, detects perforations, bifurcations, no lip clip. And the disadvantages are no digital readout, difficult to operate, requires coded probes, need for individual calibration. The device had to calibrate it at the periodontal sulcus in each tooth. Third generation apex locator. Third generation electronic apex locators are similar to the second generation ELs, except that they use variable frequencies to determine the distance from the end of the canal. In the coronal portion of the canal, the impedance difference between the frequencies is constant. As the file advanced apically, the difference in the impedance value begins to differ greatly with maximum differences at the apical area. These units have more powerful microprocessors and are able to process the mathematical quotient and algorithm calculation required to give accurate readings. The examples are Propex, Bingo 1020, Justy 2, Index, Root ZX, Mark V Plus, Copilot, Endo Analyzer 8001. Advantages are easy to operate, audible indication, can operate in presence of fluids, analog readout, uses key file. Disadvantages are requires lip clip, chances of short circuit, needs fully charged battery. Fourth generation apex locators. These are ratio type apex locators which determine the impedance at 5 frequencies and have built-in electronic pulp tester. These devices not process the impedance information as a mathematical algorithm. but instead take the resistance and capacitance measurements and compare them with a database to determine the distance to the apex of the root canal. Examples: Neosono Ultima ZX, fifth generation apex locators. It measures the capacitance and resistance of the circuit separately. It is supplied by diagnostic table that includes statistic of the file. They have best accuracy in any root canal condition, dry, wet, in bleeding canal, with saline EDTA, NaOCl. And the example is eMagic Finder. Sixth generation apex locators, also called adaptive apex locators. There is multi-frequency operating system. Sound operated switching device can produce different kinds of sounds to indicate the different positions of file in the root canal. Dry and wet conditions are also available for accurate reading. Generation of apex locator and operation days. We can see a chart here. In first generation, measurement of electrical resistance. In second generation, there is measurement of electrical impedance. In third generation, using two different frequencies at the same time in order to measure the difference or ratio between two currents. In fourth generation, using two or more non-simultaneous continuous frequencies in order to measure the difference or ratio between two currents. In fifth generation, measures capacitance and resistance of circuits separately. There is a journal club presentation which says that comparison of tentative radiographic working length with and without grid versus electronic apex locator. Introduction. One of the key concerns in the root canal treatment is working length determination. To determine how far the working instrument should be advanced within the root canal, along with the point of termination for the preparation and observation. Anatomically, the apical constriction (AC) is a logical location for working lines since it often coincides with the narrowest diameter of the root canal. Electronic apex locators determine working length with better accuracy in complement in assistance with radiographic methods. The age-old radiographic grid method is no more in practice but still has its role in determining the working length. Till date, there is limited literature available regarding the uses of grids to overcome the disadvantages of conventional radiograph in endodontic practice. Hence, a study was planned to compare and evaluate preoperative estimated working length with conventional radiograph and with grid radiograph with reference to EL in single rooted teeth, material, and method. There are 30 permanent teeth, single root, indicated for RC teeth. A conventional radiograph and grid radiograph were made for each tooth before access opening, and the tentative working lengths obtained by them were considered as group 1 and group 2 respectively. After access opening and pulpectomy, root canal was irrigated using 3% sodium hypochlorite and was aspirated. No attempt to dry the canals completely. The apical constriction was located with the root ZX apex locator according to the manufacturer's instructions. The size 10K file was advanced apically into the canal until the beep sound was heard and the light emitted diode LED marked apex on the panel began to glow, indicating that the tip of the file had reached the anatomical end of the canal. The file was withdrawn with the slow counterclockwise turn until the red LED apex light turned off and green LED light illuminated and a rapid tone was heard, suggesting that the tip of the file was at the predetermined length of the AC. The distance from the file tip to the incisal edge was then measured and registered as final working length, and it was considered as group 3. Result. The results of the study showed a higher correlation between grid working length and apex locator working length than conventional working length and apex locator working length. Preoperative metrics with radiographic grid along with the apex locator is a better measuring tool compared to the conventional radiographic working length in a single routed probe. Electronic methods for working length determination has progressed substantially and has gained popularity in modern endodontic treatment. A number of in vitro and in vivo studies on the accuracy and reliability of the root ZX have been reported, which give precise and accurate measurements. However, this is not superior to digital radiographic methods when used alone. An alternative for the conventional radiographic method, radiographic grid was developed. Everett and Fixed were the first to use metallic grids for working length determination. Considering the results of the present study, when the three groups were compared, there was a statistically significant difference between radiographic working length and grid working length. Electronic apex locator working length and radiographic working length. There was no difference observed in between PALWL and grid WL, whereas PAL is electronic apex locator. Conclusion. Preoperative metrics with radiographic grid along with apex locator is a better working length measuring tool compared to the conventional radiographic working length in single routed teeth, thus preventing a confirmation radiograph at final working length and can be useful in patients who need not to be exposed to repeated radiation because of mental, medical, or oral conditions. Evaluation of working length determination methods and in vivo or ex vivo study. This comparative study was done to determine the accuracy in measuring the working length of root canal using tactile method, electronic apex locator, and radiographic method in vivo and comparing the lengths so measured to the actual working length ex vivo after extraction. The results indicated that among the three methods, the electronic apex locator showed the highest accuracy and the highest reliability for working length determination. An in vivo evaluation of different methods of working length determination. The purpose of this in vivo study was to compare the ability of digital tactile, digital radiographic, and electronic methods to determine reliability in locating the apical construction. Result. The percentage accuracy indicated that EAL method shows maximum accuracy, i.e. 99.85%, and digital tactile and digital radiographic method showed 98.20 and 97.90% accuracy respectively. Comparison of working length determination using apex locator, conventional radiography, and radiovisiography, and in vivo in vitro study. The purpose of this study was to compare the working length determination done using three methods, namely apex locator, radiovisiography, and conventional radiography. Result. The results revealed that all the three methods located the apex nearly as accurately as the actual root length obtained by histological ground sectioning, and among three methods, apex locator being the closest to the actual root canal length. Precision of endodontic working length measurements. A pilot investigation comparing cone beam computed tomography (CBCT) scanning with standard measurement technique. A study was conducted to evaluate the utility and precision of already existing limited CBCT scans in measuring the endodontic working length and to compare it with standard clinical procedures. Result. suggested that great correlation was found between the endodontic working line as measured in the CBCT images and the EAL. Thank you guys for there is one more thing called as working with the initial and post instrumentation horizontal dimensions of the root canal system at working length and other levels. The horizontal dimensions of the root canal system is not only more complicated than the vertical dimension, root canal length or working length, but also more difficult to investigate because the horizontal dimension varies greatly at each vertical level. Factors affecting working with determination: canal shape, canal length, canal taper, canal curvature, canal contain, canal wall, irregularities. Without the knowledge of above factors, keyhole or dumbbell effects can occur with reaming or modified reaming actions. So circumferential instrumentation can conform to the outline of horizontal dimensions of root canal at different level of canals. Apical widening concepts by various authors. Constant concept in maxillary teeth, central incisor has recommended apical enlargement 70 to 90, lateral incisor 60 to 80, canine 50 to 70, first premolar 1 canal 50 to 70, 2 canals 35 to 50, 3 canals 35. In second premolar 1 canal 40 to 70, 2 canals 35 to 50, 3 canals 35. In molars, mesiobuccal root with 1 canal 35 to 50, mesiobuccal root with 2 canals 35 to 45, distrobuccal root 40 to 60, palatal root 60 to 100. In mandibular tooth, recommended apical enlargement for incisors with 1 canal 35 to 60, with 2 canals 35 to 50. For canines, it is 40 to 70. For first premolar, it is 40 to 70. For second premolar, with one canal, 40 to 70. With two canals, 35 to 50. In molars, with mesial root, 35 to 45. With in distal root, with one canal, 60 to 80. In two canals, 40 to 60. There are few points against it. Bean et al. Stated that bringing every canal to similar size is incorrect as some canals will be vastly over prepared and others will be insufficiently clean. Du et al. 2000 stated that that since diameters of apical canals vary greatly in all tooth groups, no standard size is advisable for apical enlargement. Bean's concept: the canal enlargement should be done three sizes greater than the first file binds. 2 points against it. Uh, Taking successively larger files to same length in curved canal lead to apical lacerations or lesion. Liu et al. Stated that the first file to bind didn't reflect the apical diameter and aim of removing infected dentine may not be achieved. To sum up, not possible to determine canal diameter from radiographs. CT scans are needed. Canal width depends on file type and reflaring. Yu et al. Diameter of the binding instrument was smaller than canal diameter in 90% cases. Reflaring is essential. So, keeping in mind all the above mentioned factors, canals should be enlarged until necrotic dentine is removed and search still goes on. Thank you.